Could FDA-approved Vyvgart, efgartigimod alpha FCAB for intravenous infusion, or Vyvgart Hytrulo, efgartigimod alpha and hyaluronidase QVFC for subcutaneous injection help your adult patients? Explore clinical trial data and learn how to get patients started at vyvgarthcp.com. Vyvgart is a registered trademark of argenx. Vyvgart Hytrulo is a trademark of argenx.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Jeff Ratliff with the Neurology Podcast and Thomas Jefferson University. I'm speaking with Maureen Leehey from the University of Colorado. Maureen and her colleagues authored a paper in the journal Movement Disorders titled Short-Term Cannabidiol with Delta-9 Tetrahydrocannabidiol and Parkinson's Disease, a Randomized Trial. In this single-center randomized control trial, patients with PD were randomized to receive oral cannabis extract with high CBD and low THC compared to a placebo group. Patients were followed over 2 weeks, and outcomes on the Movement Disorder Society Unified Parkinson's Disease Rating Scale, or UPDRS, and other clinical measures were assessed. Listeners who care for patients with Parkinson's disease likely encounter a number of questions from their patients and their families about the state of knowledge regarding cannabis-derived compounds for Parkinson's-related symptoms. Maureen, thanks for joining us.
My pleasure.
Maureen, there's a number of results to unpack in this paper that we're going to get into, but can you briefly summarize what you found with regards to the effect of the cannabis extract you studied on the patients in your trial?
Yes. So many might be surprised, but we actually found no benefit. We have found no benefit for motor symptoms and also for non-motor symptoms. And this study was controlled, and we measured blood levels of the study drug. Actually, those in the CBD THC group had mildly worse cognition and sleep.
I'm looking forward to getting into that. And before we do, for those unfamiliar, the world of cannabis-derived products that are available in different states with different levels of cannabis regulation can be overwhelming. And so can you tell us specifically in this study about the cannabis extract you used in this trial, and what did we already know about similar compounds, specifically in patients with Parkinson's disease?
The compound that we used in this trial was an extract from NIDA, and they gave us basically some black goo, and we took that and turned it into a formulation that patients could take by mouth. We dissolved it in sesame oil and added some peppermint to it, and it ended up to be 100 milligrams of CBD plus 3 milligrams of THC in 1 milliliter, which they would take twice a day. So this was quite a feat, though, to get this study drug, because in the U.S., researchers are restricted in terms of where you can get study drugs, a lot of regulations, because it's a Schedule I substance. So we did know that we wanted to use CBD more than THC. In Parkinson's, then CBD is a better choice because studies outside of Parkinson's had shown that it seemed to reduce anxiety and psychosis, which are big problems in Parkinson's, while THC actually did the opposite. It is known to increase anxiety and cause psychosis, hallucinations, etc. So we knew that we wanted it to be mostly CBD, but we also knew that we wanted to study cannabis, so we wanted to have a little touch of THC in it. And in fact, CBD, there's a theory that you need a little bit of THC in it to sort of ignite it, to sort of make it actually effective. The two cannabinoids working together are more effective. We knew of a prior study that had shown that CBD at 1,500 milligrams a day caused liver dysfunction. And so that gave us an idea as to what dose we wanted to use. And we wanted to use doses and formulations that would match what people were taking actually in the United States when they would get it from a dispensary, the so-called medical marijuana. So what we already knew about cannabis products and their effect in Parkinson's, there had been 8 randomized controlled trials, All of these have been done outside of the United States because of the regulations here. But these trials, there were no consistent conclusions that you could make from them because they all use different formulations. So another problem is that they didn't measure cannabinoid blood levels, so you didn't have an absolute confidence that the dose that the patients were actually getting. So although there were those randomized controlled trials, we didn't have solid signal for what was helpful or not helpful from specific cannabinoids or doses. But there has been a lot of anecdotal reports, a ton of anecdotal reports. And we were involved in one study that was actually sponsored by the Michael J. Fox Foundation, in which 1,800 Parkinson's patients taking cannabis were surveyed. And they were taking a wide variety of cannabis formulations. And the take-home message from that study was that those that were taking THC more frequently reported benefits and adverse effects than those on CBD. So it seemed like that THC was having an effect more so than the CBD was a stronger effect.
In this study, like you said, this compound in particular was high in CBD with a low but non-zero THC content for what you just said, that maybe there's a synergistic effect there. And so let's get into a little bit about the study intervention. How were patients in the study taking the extract that you were administering? And you also touched on in your last answer about the variety out there of how patients are taking different cannabis compounds. And so this compound that you were using in this intervention, how does that compare to some of the more quote unquote typical use that patients may be taking cannabis out in the real world, so to speak?
Our patients were taking study drug that we dissolved in sesame oil. And the way that they would take it is they would use a dropper and they would put 1 milliliter in their mouth in the morning and in the evening. But in real life, there's lots of different options. If you go to the dispensary, you have the choice of getting products that you inhale or that you take orally. So for example, with inhalation, that would involve smoking or vaping, or another method called dabbing. Dabbing is where you have a very concentrated product that is 80% THC, and you inhale it, and it can be fairly dangerous, especially in our elderly population. So we're hoping that none of our patients are doing that. But in general, inhalation is probably not a good idea. You feel the effects quickly within minutes, and so it's usually done with THC, and patients feel high. There's the interesting that we have noted that patients with Parkinson's and elderly folks don't feel great about being high. It makes them anxious and it makes them dizzy. So it's a little bit different than younger folks. Also, smoking, you're getting the toxins from combustion. And when you're inhaling, then you're usually using equipment that is more technically difficult for elderly Parkinson's patients. So oral is what a lot of people with Parkinson's end up choosing. And that could be oil, gummies, cookies, chocolate pieces. In that case, it only takes about 30 minutes to feel the effects. But it can take hours. And sometimes people will take a piece and then they don't feel anything. So they'll take another piece and then they don't feel anything. And pretty soon it all hits them too much at once. So yeah, it can be tricky and of concern. Also, oral includes tinctures and liquids.
So as you said, patients were taking 1 drop twice a day, and that certainly allows you to control the dosing. And like you just said, whether it's inhaling or with other edible compounds, there can be variety in terms of how much of a dose of compound people are getting. And so in this study, we're looking at this twice a day dosing. And I want to focus on the motor subscore of the Parkinson's disease rating scale. And it looks like I'm looking at the study that there was a reduction in that motor score, and for those unfamiliar, implying an improvement in motor signs and symptoms on examination, but that didn't seem to differ between the cannabis group and the placebo group. And can you dive into those results a little bit? What did you find with regards to motor scores in your 2 groups? And is there some placebo response driving this, or is there more than meets the eye in the results that you did find?
Yes, the primary outcome was the motor MDS-UPDRS score. And patients did not have a difference between the CBD and the placebo groups. The CBD group improved more than the placebo group did, but there was not a statistical difference. But having a placebo effect of such magnitude is problematic. And part of the thing is that this was only a 2-week study. So if you have a 2-week study, then it's not really long enough for the placebo group to be accounted for. You need more like a 3-month study. We could only do a 2-month study because we could only get a limited amount of cannabis drug. But we think that part of the reason that patients had so much placebo effect was because it was exciting taking a previously illegal drug that probably fueled the greater placebo response. I think we all know that Parkinson's patients can be optimistic and hopeful, and they tend to have a greater placebo effect than other populations.
Maybe some challenges with the scheduling of the drug itself and having that 2-week window to study, but certainly in that time period, doesn't seem that there's a statistically significant improvement in motor scores with regards to the patients in the study. And so I want to pivot over to some of the non-motor outcomes. And listeners may recall that I had a conversation with Meredith Bach back in May of 2022 talking about the impact of non-motor Parkinson's symptoms on measures of health-related quality of life. So we know that non-motor symptom burden is certainly important for us to look at. And so, Maureen, acknowledging that these outcomes were secondary outcomes in the trial, but what findings did you have when it came to the impact of cannabis on non-motor symptoms in Parkinson's disease? Which ones did you look at and what did you find?
We studied really everything non-motor. While we had a chance to give cannabis to Parkinson's patients in the United States in a controlled study, then we wanted to be as comprehensive as possible. And of course, Parkinson's patients have the motor symptoms, but are really, really bothered by the non-motor symptoms. And since cannabis was suggested to help specific non-motor symptoms, we made sure to study everything we could and focus on those. For anxiety, we administered 3 separate questionnaires, and there was no difference in the groups. We looked at pain. That was 2 questionnaires. There was no difference in the group. We looked at sleep, and we studied sleep pretty thoroughly. We included polysomnograms. There were 2 questionnaires, no difference. But interestingly, when we asked the caregivers specifically in a questionnaire, they felt that CBD group were worse. So the caregivers of the patients taking CBD said that the patient's sleep was worse, whereas the placebo group caregivers did not report that so much. The polysomnograms, there was really no difference in the sleep. And we studied architecture. What we saw was a ton of sleep apnea, but it wasn't different between the 2 groups also. Then cognition, that's probably a major thing. That would be of concern to any doc that was thinking about their patients taking marijuana. And we did neuropsychological testing. Then we found that there was a small but significant detrimental effect. And then also caregivers reported more trouble with concentration than those in the placebo group. In kind of summary there, we felt like we weren't seeing any evidence of help in anxiety or pain. Sleep might be worse, and cognition, there was a pretty clear signal that it was at least a little worse.
It sounds like even in the non-motor symptom assessments that you did, cognition measurably worse, sleep quality to the caregivers not as good in the patients receiving cannabis, which kind of is a segue into my next question, where I wanted to ask you about safety and adverse events. And while those of us who see patients with Parkinson's probably encounter a lot of curiosity about cannabis for their Parkinson's, I also hear a lot of apprehension and worry about the side effects of cannabis. And you touched on some of those, specifically patients who are feeling high on THC, can feel dizzy, and that's an unpleasant effect that they might have. And so what did this study teach us about safety of cannabis use and adverse effects of cannabis use in Parkinson's disease, specifically with your compound, which was high in CBD and low in THC?
We saw that there were twice as many adverse effects in the CBD THC group than in the placebo group. And the most common were dizziness. And overall, though, most of the side effects were mild. And interestingly, they were mostly occurring at the onset. We also saw that there were no changes in vital signs. And that's important because folks know that THC in particular can cause tachycardia. And our patients are so fragile. We specifically checked orthostatic blood pressures and saw no change in that also.
Summarizing things, the million-dollar question here is, how do the results of this study change our approach to the use of cannabis in patients with Parkinson's disease? And we've talked about your study not finding improvements in motor scores, finding evidence that cognition and sleep quality was worse in patients receiving cannabis, and that, albeit mild, there were some other adverse effects and unwanted side effects of dizziness as well, especially in the early stages. And so going forward, and I'll ask you for your expert opinion here, when you see patients with Parkinson's disease in your clinic and they come in and they want to learn more about what they might stand to gain or lose from cannabis treatment, how have the lessons from this study influenced the conversations you're having with them?
We need a lot more research. But in terms of motor symptoms, it seems unlikely that cannabis is going to be all that helpful. There's been enough studies here and there looking at different formulations and not getting much of a signal. It's pretty unlikely that CBD by itself, pure CBD, is likely to help motor symptoms. I still think that maybe tremors should be looked at a little bit more. For non-motor symptoms, then sleep might be a consideration, but the problem is that most of the time patients with Parkinson's have trouble staying asleep, not falling asleep. So I'm not sure how much sleep will be helped by cannabis preparations. For anxiety, then it might be useful to try CBD, but not particularly THC. So in general, I would say that the cannabis preparations you can get at the dispensary are not ready for prime time in Parkinson's disease, and you really have to be cautious with the THC.
So it sounds like there's information both from this study that begets further trials and further studies, and caution is certainly still needed, and there might still be some domains in the symptom burden that patients with Parkinson's are experiencing where CBD might be helpful. You mentioned pain, maybe with anxiety, maybe looking further at tremor, perhaps going forward with bigger studies. But it sounds like caution and certainly watching out for some of the pitfalls that patients can run into should be the rule when we're having these conversations with patients. Well, Maureen, that was fantastic, and thank you for teaching us. I've been speaking with Maureen Leehey from the University of Colorado about her and her colleagues' paper published in Movement Disorders titled Short-Term Cannabidiol with Delta-9 Tetrahydrocannabidiol in Parkinson's Disease, a Randomized Trial. The paper was published in March of this year in the journal Movement Disorders, and so please go check that out and read the full article to learn more. Maureen, thanks again for joining us.
Thank you for the invite.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.